Hello and welcome again to another breastfeeding session. It's quite exciting really because I've done one, now this is two. It's a whole new thing for me, so I'm trying to enjoy it as much as I can, but the technology is fascinating. Welcome, and I hope you enjoy today's session. I would like to just remind people that because I don't have a detailed history from each woman that's asking a question, I do have to answer in the broadest sense. So if you would like more information, you can contact me via my team, and then we can do Skype session if you prefer that. Some of the answers to the long questions today will appear in writing on the blog. They will be de-identified, but the people who ask the question will know because I'll put the question up as well. So we will cover that for you, but they're quite long questions with lots of points in them. So sometimes it's a bit hard to bring all of that together. So it's probably better to make a written response as well. And if you have any concerns at all, my advice is that you seek the support of your midwife, the advice of health professionals that you work with, and don't hesitate if you have a genuine problem that you're concerned about. This is something we can't deal with, or I can't deal with in distance like this, but I can deal with a broader sense of questions. So welcome to today's session, and I'll do my very best to answer as much as I can. The first question today is from a mother, Amanda. Amanda has a baby that's 11 weeks old, 5 weeks corrected, so it was a little baby that was early. So she is saying that her baby used to pass poo a couple of times a day and has all of a sudden stopped. We've only had one, but large poo in 6 days. I don't believe that I've changed anything in my diet, but my diet, could my diet be contributing to all of this? I've also bought some prune juice for myself to consume, hoping that will pass into the baby, encouraging more poos. Is there anything else I can give him to help, or is it normal that I shouldn't be worrying? I've also been giving him 50 mils of water each day. Is that quantity too much? So thank you, Amanda. There's quite a lot of points there. So let me just briefly cover them, and then the detail will appear in writing for you. And so thank you for your question. And let's talk a little bit first about corrected age. This is used on the basis of a 40-week gestation. So in the broadest sense, the gestation ranges between 38 and 42 weeks. So, even though it's used on a 40-week gestation, there may be some leverage either way because of the expansion of gestation. Every mother and baby is different, and every family history is different too. So I do hope it helps you to understand some of the possibilities during this time. I must just mention in this point too that in my practice, the average gestation for women who birthed at home over 25 years was 41.5 weeks. So it's corrected age, and I don't know your baby's corrected age, but you will know that. Let's talk a little first about the questions that come to my mind. Has your baby been feeding well since birth? Has your baby been reaching average expected milestones, growth and development patterns? Has your milk volume been satisfactory according to your assessment with your baby since when your baby was born? And it seems that it has, because you're well aware of the baby's output, which is very important. My observation has taught me that babies reaching the age of around 12 weeks, this is without corrected age of course, a sudden change in the consistency and frequency of the poos can be evident. Around this time, the baby begins to retain stools for longer, and so during this time, fluid is reabsorbed, and therefore the consistency tends to be more thicker, a little bit drier. So it often changes to something like, I would explain when I'm talking to a mother that when you squeeze a toothpaste tube, it becomes that sort of thickness. So you will see changes around that time. The baby's reabsorbing fluid, all the nutrients are being reabsorbed, the volume has now settled down, so it's taking longer to pass. And, you know, a stool a day or a stool a couple of days is fine. And sometimes some babies in my practice have actually gone up to 10 days, but then they've done a great big poo after that. It's rare for breastfed babies to be constipated. They will pass their stools in good time. And so patience as long as they're breastfeeding well. Now, just let me cover. Sorry to do this to you. It's hard for me to remember it all, so I have to keep referring to the notes. Prune juice could be a short-term. So the other question was, is your baby feeding around 7 times in 24 hours? And if so, it's unlikely. If you see your baby changing to drawing and swallowing and poos and wheezes okay, then it's unlikely that there's going to be constipation. Prune juice is a short-term solution. I'm not aware of the evidence of this approach. It's worth you taking note to see if your baby has any other reaction to prune juice via your breast milk too. So we don't know what these things do when they go through the breast milk. These may be changes in your baby's behaviour, could be crying and unsettled with possible gastrointestinal disturbance if it affects the baby that way, or fussing and refusing at the breast because maybe it's changed the taste and smell of the milk. If you are thinking he's stimulating hormone and drawing and swallowing enough, then I would say that would be my guide. If I was sitting beside you and watching, I would be quite happy if your baby's drawing your breast milk regularly over the breastfeed, which takes about an hour, and maybe a little bit less at 3 months, maybe 40 minutes, something like that. There's no real time. It's about an average feed lasts about an hour by the time you've done a nappy change. So again, I'll put this in writing. Cool boiled water, in my experience, is definitely satisfactory. The important thing is to know whether the volume of your breast milk satisfies your baby first, and that your assessments take the water intake into consideration. Is he growing satisfactorily? Is he sleeping adequately? Is he breastfeeding rhythmically and regularly, both breasts, with a rest and digest period after each feed, so he has time to pre-digest that milk in the stomach first, about 7 times in 24 hours, as I said before. Is he symmetrical on face-to-breast contact each feed? And if not, can you fine-tune him so he can use his oral cavity to full potential? So when he's symmetrical at the breast, he has best potential to use your nipple and breast tissue to stimulate hormone production and to bring in the milk and to bring down the milk. And is he drawing and swallowing? And when you, at times, do you see milk leaking from the ducts or spraying from the ducts? And definitely the draw-swallow rhythm is really, really important. So I've covered those points for now, and I do hope that helps you with your little baby, Amanda. My team will be watching for any other responses, and that the response in writing will go on the blog. Next one is from Catherine Alam. Catherine, I noted about 8 points in your story. The story's quite long. So the 8 points are your baby's 3 months old, you have had implants for 9 years, you're using nipple shields, you're feeding 1 breast per feed, if I've read that right, you're giving your baby 1 bottle of express breast milk at night, you're expressing in the night because the baby's sleeping, or in the day, is that because the baby's sleeping? I think you're expressing in the daytime because the baby is actually sleeping. You're concerned about the volume in your left breast, whether it's okay in the morning and the afternoon, and your baby's fussing and crying later in the day. Again, I have to do my best to interpret your situation without having taken your history and sitting beside you and watching you feed. It is so. In my practice, 1 breast per feed has been a common denominator in leading to low supply by 3 months. I've noticed this so many times, and that's what was teaching me, observing this. The long-term use of a nipple shield also reduces best potential oral cavity. There is a video clip, I think, on this, on nipple shields and dummies and teats, so probably it would be best to go and have a look at that, and I'll give you the written response. But the baby cannot use your nipple and breast tissue to best possible oral capacity with a nipple shield, because the nipple shield's short. Your nipple will only go to the end of the nipple shield, and the baby has to use a completely different oral function to adapt to the nipple shield. So that could be adding to the problem if the problem that you're expressing that you have is in low volume. So stimulating is the problem with the nipple shield. I'm not saying they're not to be used, but I'm saying these are the points. One bottle overnight is another reason that may reduce your milk volume too, because hormone production is not being released on the baby's oral stimulation, drawing and swallowing at that time. The pituitary gland needs to be stimulated regularly around the clock. So nighttime feeds are very important to the rising of prolactin and oxytocin in your bloodstream. So if you are sleeping and not giving the baby the bottle and you think you've got low supply, it would be better for the baby to breastfeed during that time. Now, women can breastfeed with implants. In my experience, though, I have noticed that it has reduced the capacity to produce adequate volume over time for some women. I understand that the implant may take up some of the capacity for milk storage space as the milk increases ready for the next feed. I know that the implant goes behind the ductal networks, behind that part of your breast, but the room for milk storage is apparently reduced. And again, this will be for individual women, and it's not one answer for everybody. So it's women who do breastfeed with implants, and that's probably the way I'd be looking at it. Expressing in the morning because the baby is sleeping is okay because you're stimulating hormone, but if you were to leave the baby and not express and leave the baby to wait for a feed at that time, would you still have 7 feeds in 24 hours? If so, or are you compensating for the baby not feeding at night and in the morning? I don't quite understand what your picture is, but it's really important that your baby is at your breast 7 times roughly. Could be 6, could be 8, but it's an average of about 7 times feeding from both breasts over 24 hours. If you are to maintain hormone release from your pituitary gland on a cyclical or right around the clock and a regular basis, then that's how milk production is made. There are a lot of things that people use to help milk production, but the human body produces milk by stimulation of the pituitary gland. That's by the baby feeding. It does appear from your story that you could have some low volume, and that's my assessment of reading. That may be why the afternoon seems the baby's unsettled, because the volume's not quite as high by the afternoon. And one other common reason for fussing and crying babies, again, in my practice, occurs when a mother is swallowing a common denominator every day. Now, I think these are 2 different things, but I think it's important to mention as well. This appears to irritate the baby. So if a mother's swallowing, say, regularly some vitamins or taking supplements at the same time every day, then there will be a pattern to what happens. The baby about 6 to 8 hours later will become unsettled on many occasions, probably not all, but a lot of babies get very unsettled, and especially in the afternoon if mum's been taking the supplements in the morning. They're very potent, so when you chew the tablet or when you cut the capsule and you put it in your mouth, the potency is very strong. And I believe that's what comes through the breast milk, and the babies don't like the taste and smell. Babies are also fussing around ovulation as well. Taste and smell of the milk changes when the hormone changes during ovulation and menstruation. So, and also with contraception. So they're another things to think about why your baby might be fussing, might be unsettled, might be breast refusing sometimes. So, and I've written this in a little bit more detail when that comes to you. Let me just see. So the common, in my database, in my research, the common swallowing supplements, the women that are swallowing supplements were taking fish oils and multivitamins. And they described with the multivitamin very bitter taste in their milk, and with the fish oil, it was potent fish oil in the breast milk. And you can see the baby's behaviour, you can see their faces. They actually want to feed, but they don't like what's happening. They'd also been taking these in pregnancy as well, so continued on through breastfeeding. I'm not sure what you'd like to do, Catherine. If you intend on increasing your volume, it's important to breastfeed, offering both breasts every feed, if you could possibly do that. That would be my advice. And night feeding is very important to enhance your hormone release and to keep that cycle going. The other is to be sure the baby's symmetrical at the breast, that has best possible chance of working your breast, releasing hormones and drawing down the milk so that there's more milk regenerated. I think we've covered most of that. I think you'll find in some of the video clips there'll be a lot of this reiterated as well. So if you like to have a look through the ones that suit you, you might be able to glean some more information from that too. So I hope I have interpreted your story properly, and thank you for joining us. Now, this is another quite long one. So this is from Emily Sullivan. Emily has two questions. She has I won't repeat the questions here, I'll just talk about them. So her first question is her baby's around 3 months old, and around 3 months old babies do become unsettled. So I would ask Emily, are you swallowing anything, of course you're swallowing things, but anything that's a common denominator every single day? And have a look at the video that explains this that I've just mentioned in the previous one as well. Gastrointestinal systems are quite sensitive to the potency of these things in my experience. And I've seen the babies behave, and after the mother stops these things, in 48 hours, the babies begin to settle down. So they're even drinks, vitamin drinks, all those sorts of supplements. So I'll be looking to see that urine and poos is okay, that the baby's the colour's good, activity's good, baby's comfortably gaining weight, that meeting milestones, and you're generally happy with the baby's activity. Another thing to consider is the baby's sleeping longer on a regular basis at night or having consistent gap in breastfeeding in a 24-hour period. If so, this could result in ovulation. And sometimes you can ovulate, but you may not menstruate for some time down the track, but ovulation's quietly occurring. So, and this can, in my experience again, create that restlessness, that like there's a change going on and the baby's aware of it, smell and taste changes. So in the second part of this question, you asked about expressing. I believe it's better for the baby to feed both breasts if you can do, instead of expressing one while baby's on the other breast. It depends why you're actually doing that. I don't understand why you're doing that. Also, to maintain face to breast symmetry, that's very important. And the other thing is the baby may drink more, and express volume may not be high. If you express, let me just have a look at this for a minute. If you're expressing to increase the volume or save milk, it's preferable to express at the end of each feed rather than during the feed, because you want the baby to drink that milk from both breasts. What you're doing when you're expressing at the end of the feed is you're stimulating more hormone, which over the next 24, 48, 72, 96 hours starts to increase the milk volume. So you can express after a feed and save. If you're getting more than 30, 40 mils, I would say separate it, because babies don't drink milk from the two breasts at the same time. And if the volume's getting higher, what happens is they end up with tummy ache when you mix it all together. So they end up that colicky pain, because that's not how it's meant to be delivered to the stomach. One breast at a time is the right ratio for the baby's digestive system under normal circumstances. So again, there's a video on the expressing technique, and I would encourage you to have a look at that, because the technique is really important to increasing hormone production and for the milk to come down. It creates a rhythm, and the rhythm and the cycle is important. So please relax and feed both breasts, each feed with a rest and digest period and a nappy change in the middle, and follow that 2 breasts per feed if you can. And I think the rest you'll see written in the blog response. I hope this meets your needs, and thank you again for participating.
It's a similar, just that.
Okay. This is from Nika.
Oh, Vanessa.
Oh, sorry, Vanessa. Okay. Wow, questions are coming. Thank you. Vanessa's got a little baby, 14 weeks old. And she says, how can I combine breastfeeding and expressing without overstimulating the breasts and avoiding potential engorgement? Well, that's a little bit confusing for your pituitary gland. It depends why you want to do this. So what will be your cycle? What will be your plan? How will you maintain this? Because it can be very time-consuming and quite exhausting doing all of this, and doing it to keep the rhythm and the cycle created. So I would feed both breasts per feed, and then express afterwards if you're looking to save and store. If you I don't know why you're doing it, so it's similar to the previous question that I've just answered, and that will be on the blog. Response to that will be on the blog. So if you have a read through that, you will be able to see why it's important to let the baby keep the rhythm. And if you want extra, express preferably during the day, because you want to sleep at night after each feed, and collect some for whatever your needs are or your baby's needs are to be able to carry on. So again, it's not clear for me why. Is that it? So we're just, Marie's just helping you now with some more.
The question at the bottom is from Rhiannon.
From Rhiannon.
She's online.
Now Rhiannon's online. Now, is this, hi Rhiannon, how are you? Is this the 6-month-old little baby biting?
Yes.
Ah, okay. Oh, I'm sorry to hear that. But you know, little babies are very clever. At 6 months, they're teething, right? And leading up to 6 months, they're teething too. And then they continue teething on and off right up till they're 2. So there's a whole lot of changes that go on during that time. But with the little baby who's got some incisors coming, what they do is they draw their tongue back to protect the underside of their tongue from the sharp teeth that are erupting. And so you can imagine those little teeth are rubbing on the underside of the tongue. It hurts. So what they do then is the teeth come in contact with your nipple and they cause you pain. So my suggestion to you, your baby's 6 months old now, so they're actually able to understand and feel the vibrations from your chest and know that it's hurting you, that it's causing you pain. Really, really important with this is that the baby's drawing your nipple and your breast to full potential, that the baby's symmetrical at the breast. If they're on the end of the tongue, it can hurt quite a lot. So that's why they're protecting their tongue. So we want the baby to be actually drawing really well. So face to breast, lips over nipple, and lining up lips to nipple so the baby can actually draw, fine-tuning after if you need to, nose, chin, both cheeks, and that's all on video for you. But it's very, very important that you talk to your baby. Talk to your baby eye to eye. Talk to your baby, and when it's hurting, use the same word, the same sounds, whatever it is for you and your baby, that let your baby know it's hurting. And the vibration through your chest, your baby becomes aware of it. I'm not keen on taking the baby on and off when they do this. It's like you're a naughty baby, you have to come off, but they don't mean to be naughty. It's a protection method for their underside of their tongue. So snuggling your baby, cradling your baby, talking to your baby, and letting them feel that vibration, and then they start to learn, oh, it hurts. But most importantly, to be nice and snug at your breast. I hope that helps. It will get better, and then when new teeth come, but as the teeth here further apart, the incisors are through, and then the canines come, and then the 1-year-olds, and then later on they have a lot of problem with the little 2-year-olds. 2-year-old tantrums, don't believe in those. I think they've got 2-year-old teeth coming through, and they're huge and they hurt, and that's all connected to the trigeminal nerve on either side of the face here. So lots of time ahead with teething. I hope that helps, but it is one of the common things that happen around that time. Okay, this is from Tahima. Thank you, Tahima. If during the first week the mother feels the baby is not wetting the nappies or diapers as recommended, can you supplement with formula or keep breastfeeding until it is established? So the first week is very early, and the volume, I'll just keep that for a minute. The volume, you can have it. The volume of milk is still actually increasing and settling down in the first week. It takes a good 72 to 96 hours for the volume of milk to peak. So you don't expect a lot of wet nappies over that time, but you expect frequent feeding over that time. So they get small amounts frequently. Once the milk's come in, and as you say, established, you keep feeding, and you change to 2 breasts per feed once you feel confident that your milk volume's increased, and you can see the baby swallowing more. You can hear the swallowing even happening as the volume increases. And then you'll see wheeze and poo start to change. Unless you're genuinely concerned that your baby's dehydrated, that your baby's not active in movement, maybe not staying as warm as it should be, you've got to be keeping your baby warm all the time, then maybe that's a different story. But I would be then expressing your breasts and giving your baby extra milk rather than cow's milk formula. Cow's milk formula is not going to benefit your baby, but your own breast milk will. I hope this helps, and if you need to, stay in touch. Thank you for your question.
First one.
Okay, this one is from...
I'm not sure who it's
we're not sure who this is from last week, is it?
Yeah.
Oh, sorry. This one's from last week, and I don't have the name attached to the question at the moment, and I'm really sorry for that, but because I do like to acknowledge you, but I'm sure when you hear the response, you'll see that it's attached to your question. Or here is the question. During the first breastfeed, do I use the rest and digest period test? So during the very first breastfeed, right, do I use rest and digest, then switch, or just continuously switch as the baby continues to search and locate? Yes, in the very first breastfeed, the baby needs just to find the breast, feed, then when the baby comes off leisurely and looks around and is feeling the environment, watching your face, knowing it's close to you, then when it's ready to go again, go to the other breast. And then when repeat that as the baby comes off, it may be for up to 2 to 3 hours before the baby actually settles to sleep. What they're doing there is drawing colostrum down from each breast through the ductal networks, gradually clearing the ductal networks in preparation for the volume of milk that's going to come down up around 72, to gradually increase up to 72, 96 hours. So we want the baby to remove the colostrum from both breasts from the first feed if that's possible. So yes, please just work with your baby and you'll do it beautifully. Thank you.
Just the next question.
The next one is my baby is nearly 3 weeks old and suffering from bad gas or wind, is in quite a lot of pain, straining, etc. What would I recommend to help with this? Well, it would be similar to the responses I've made before. If your baby's 3 weeks old, are you feeding from both breasts each feed? If you're feeding from one breast each feed, so 3 hours later the baby has the breast it didn't use last time, you'll find that the breast will be overfull. And what happens is the capacity for the stomach is far too much. So the little stomach actually expands beyond its capacity. And this valve at the top and the valve at the bottom that goes into the bowel and the one that comes up into the esophagus have to open to release the pressure in the stomach. And so you get the gassy, windy tummy ache. You might get some reflux with it too. It just depends on the individual baby. So both breast each feeds means the baby takes a volume to satisfaction, stays there for emotional satisfaction, then comes off by itself, then rests and digests, then has a nappy change, then goes to the second breast when it asks for it, when it's body language, when it's facial expression and movements, its tongue protruding, voice calling starts to ask you for the second breast. Then it has the second breast and fills to satisfaction again. And then and then hold the baby upright afterwards to let that digest as well before the baby goes to sleep. But if that's little babies, not all babies after about a month old will stay awake and look around for a little while. They don't always go off to sleep, and sometimes they need a little extra top up before they go off to sleep. But that's a little bit down the track. Here, it's very important also to take note of what you might be swallowing. If you are swallowing anything on a regular basis, to maybe try a period of time where you don't have it, say 4 or 5 days, and see if your baby settles down. Very important. And it will be, if you have, just sit and think about it, it'll be the common denominator that you're swallowing every day. And that comes from a lot of observation of thousands of babies, but also through recording in my database the sort of things that women were swallowing every single day. One of the common ones I'm seeing lately is placental capsules. Now, I'm not saying don't have them, don't get me wrong, please. But what I'm saying is you're having them 3 times a day, it may be too much for your baby. So again, it's all individual. Everything is individual. So if there's a common denominator for you and your baby, then I would be testing that. If I was working with you, I'd be suggesting you test that. I hope that helps.
Top one.
This is from Nasharine, is it? Oh, Angela. This is from Angela. My baby is a gulp feeder. How can I get him not to gulp? Well, Angela, I don't know how old your baby is. I also am not sure how you're feeding. So I'm making an assumption that you're using one breast per feed. If you are, then that would be the same response to the question before, that if your breasts are really full, your baby will be trying to cope with the very fast, high volume flow. If the baby's not symmetrical at the breast, the milk will flow forward in the mouth and then they're trying hard to get it over the back of the tongue. So your baby needs to be symmetrical at the breast to be able to have the nipple right back at the soft palatal cleft where the milk sprays over the back of the throat and sets off the swallow reflex. It actually activates the 2 months old. Okay, 8 weeks old roughly. Okay, so if you are one-sided feeding, this would be the way to go, I think. If you're expressing extra, it might be that you're making more volume. And again, these are all assumptions I'm making because I don't have a history from you. So just what the aim is to slow the volume down or to slow. So this is advice I'd give to someone that I've been seeing. I would start with the softest breast first, slow that down, give the baby time to rest and digest, wait for the baby to ask, and then give the baby some from the other breast. The problem with this, if you have a very full breast, is the risk is engorgement and mastitis. So if you ever have a full breast that feels uncomfortable to you, that you might feel a bit hot and cold or a bit fluey, it's important to take a small amount off just enough for your breast to feel comfortable. You're not wanting to take a high volume off. Just the comfort, and that sort of simulates that your baby has been there. That relieves the pressure in your breast and helps prevent the backflow or the stagnation of the milk in your breast, which can end up in mastitis and sometimes in abscess formation. Yes, I just had a message to say Angela's feeding one breast per feed. So Angela, that makes it much easier for me to understand. If you, I'm not sure, but it seems to me like it would be okay if you watch the other breast very carefully to start on the softest breast first till things settle down a little bit, till you hear the change in your baby's swallowing. Maybe you'll see a change in the output as well. And then the baby's poos and wheeze might change, and, I don't know that detail. But then, and then rest and digest, and then when the baby's ready, go to the other breast, but there won't be a lot of volume taken off it. So just be aware that you may need to take just enough to relieve the pressure in your breast that feels uncomfortable. It's all about comfort for you. Hope that helps. Thank you for your question. Now, Nashareen. Hi. Now, is it okay to feed my baby through breastfeeding one side, lying position, and my baby is lying flat? Is it okay? Then we both slept, and I did not let the baby burp since we drift off to sleep. Again, Nashareen, it depends if you've got a problem or not. If there's no problem and you're doing things the way that works for you, then there's no problem. But if you've got a baby who's unsettled because you're using one breast per feed, lying down's fine as long as the baby's symmetrical at the breast. But if the baby's flat on its back, it means it's got to turn its head to get to your breast. And then I would like to be able to see how symmetrical the baby is at the breast by doing that. Also, it can create, over time, neck ache because it's uncomfortable turning your head to breastfeed. So I would just tilt your baby into you so that lips are over nipple. Either you move up or down and your baby up and down so you've got lips over nipple and the 4 points are snug at your breast, and complete the feed and just let the baby sleep right beside you if that's what you're used to doing. If the baby's stretched out, like you're saying, and lying beside you, it's highly likely the baby will burp anyway because there's space between the diaphragm and the stomach for the air to rise, and you might even hear your baby burping itself as well. So I don't have a problem with that, although there is a lot of information around to say you shouldn't be sleeping with your baby as long as your baby's not under the blankets, but your baby's not covered, as long as your baby can have hands to mouth. That's really, really important. Not wrapped up real tight so it can't get hands to mouth, so the baby can nurture itself, so the baby can't be rolled on, so the baby can't be covered and build up carbon dioxide under the blankets. That's really important. Preferably airflow through the window is very important too, if it's not too cold. I don't know what your climate's like, but fresh air is always good. Baby's head above the blankets is very, very important. If a mother really wants to sleep with her baby and it's a little baby, I generally suggest they sleep on their mattress above the pillows if you're sleeping with another person, and they sleep the same way as you, head and feet, but on their own little mattress up there, and they're in tune with you and you're in tune with them. That's the way I would suggest that for little babies. At 8 weeks, 2 months, they're getting a little bit busy and they may not stay in one position. But if you're comfortable and you feel safe doing what you're doing, then that's fine by me.
This one, then that one.
Okay. So this is Mika, is that right?
Yeah.
Mika has a premature baby, about getting top-ups of breast milk mainly from the bottle. How can I get her to breastfeed, please? Okay, so Mika, again, my assumptions are that your little baby's been feeding via either a tube or bottle or teat since the baby was born, and my premature baby is premature baby is breastfeeding, but getting top-ups of bottled milk, mainly from the bottle. Do you know why your baby's getting top-ups from the bottle? Is she growing okay? Is she breastfeeding okay? Does she need, say, between 7 and 8 feeds in 24 hours to meet her needs that would gradually reduce the bottle? How do I get her to breastfeed only? Well, I would offer both breasts with the rest and digest, with all of that I've just explained before. I would offer that to her every feed, as many feeds as she needs in 24 hours. I don't know what her prematurity is now, what her age is now, so it's hard for me to, what her size is. All of those things make a difference. The other thing that's really important is what sort of a teat you are using. If you're using a long teat, the longest possible teat, narrow teat, that's better. And there is a video on that. Please have a look at it because it explains the teats and dummies and nipple shields and all of those things. If it's a short nipple teat with a wide base, then the baby can only chew on that, can't actually draw and swallow. So what happens is they become conditioned to the hard silicone, the shape and the size, and then they have to try and work between the soft pliable breast tissue and nipple and breast tissue and the teat, so they get confused. So it's important to offer your breast as much as possible. And even if you have a transition period where you just go, say, 24, maybe 48 hours, and just breastfeed her and see what happens. See if she transitions over a little bit quicker for you. But I'm sure you can stay in touch with me through the media if you need to. I hope that works for you. Thank you. Liesl. So Liesl says with her first baby, she experienced a lot of pain when breastfeeding. She was told she had an incorrect latch, and that was checked by an LC, and she seemed to think everything was okay. So now Liesl believes that her pain was caused by vasospasm and strong painful letdown. She's about to have a second baby, or she's pregnant, coming up with her second baby, and she says, is it possible to distinguish between pain from an incorrect latch or for physiological reasons? And can anything be done to lessen the pain from vasospasm? Well, with vasospasm, the first question I'd ask is there a family history of Raynaud's disease? Because that's a common reason why we have vasospasm. The other when I see vasospasm is when the baby's actually biting, chewing nipple. It's very painful, and it takes the blood supply from it, and it can be quite white and very sore. So they're the two reasons. But Raynaud's is a common reason and it's generally a family history with really cold white fingertips and very blanched, painful nipples. So if it was vasospasm from something like that, my encouragement would be to keep your nipples warm all the time, keep the blood flow, keep it circulating as much as possible, and especially before a feed. I think you can get little nipple warmers, little pads that actually keep the nipples warm, or that you can heat and warm. You just don't burn yourself, but that's one thing I would do so that the blood's flowing into. The next thing would be that the baby's actually drawing the breast and is symmetrical at the breast. That's really, really important, because we want that nipple to reach the soft palatal cleft, way back. If you run your tongue over the roof of your mouth, you'll feel the soft pocket. We want the baby to draw the nipple into there so it's protected in the soft pocket. It needs to be protected. And the compression is not as hard. It's hard on drawing, but it's not as hard on drawing and swallowing. When the baby's actually swallowing, the compression is softer. So the pain, if it is due to that, is eased. If the baby's using its anterior tongue, sometimes the tongue slips back and the gums will bite, or sometimes it's compressing with the anterior tongue into the bony palate, right into the bone, and that causes a lot of pain too. So first of all, is your baby symmetrical at the breast? Is your baby drawing well? Can you feel when your baby changes to drawing, and from stimulating it hurts, but then when the baby changes from drawing to swallowing, is it less painful? Is the pain reducing, or is the pain gone? That's what the women told me in my research. It was either reduced, most times it was gone. So the baby needs to draw. It needs to vacuum, because if we put the breast in the mouth, it doesn't actually use its vacuum pads and gets a mouthful of breast tissue and then has to try and work out what to do with it. When it draws along the upper surface of the tongue all the way back. So with the correct drawing and swallowing, you'll see face to breast symmetry, and you can fine tune chin and nose slightly right, slightly left. You want the point of the chin massaging deep in the breast, because inside there, the glossus muscle of the tongue is joined to there, and they work in harmony together. So if the chin's away, it pulls the nipple forward in the mouth, and the baby uses its gums. If the nostrils are hanging back, the baby again bites with its gums. So they need to be symmetrical. Nostrils on the breast, resting gently. Lip sits here for breathing. Just breathe through here. And then both cheeks snug at the breast. And you can just adjust that whichever side you're holding your baby. You just gently turn the upper shoulder or gently turn the bottom shoulder. Gently move right or left for chin and nose. It's no more than a centimetre. It's very, very gentle. It should, if that's the problem, should help reduce the pain for you. With the first breastfeed, maybe if you had a look at my video clips and try and get the very first breastfeed and the very first 72 hours together without intervention, without interruption from anybody handling and taking your baby away from you. Mammals are meant to be with their mothers and not meant to be separated, unless there's an urgent or emergency reason to do so. So if you can get that part right, it may make a difference to the experience that you had last time, if you don't have something like Raynaud's or the vasospasms due to the way the baby went to the breast. I hope this works well for you. Would you let us know, please? Thanks. This is from Sharon Spencer. Sharon says her baby is 8 weeks old and she's finding that he will always vomit after feeding. Is that normal? I've been breastfeeding on both breasts like you have advised, and the feeds vary from 1.5 to 3 hour feed intervals. So he's sleeping on the average, start of feed to start of feed is about 1.5 to 3 hours. So when the interval between feeds is taken from start of feed to start of next feed. So he's vomiting after. So my question is he's 8 weeks old, he's 2 months. Is your volume very high? Has anything changed in your swallowing, eating, drinking? They're the sort of things that I would be asking questions and documenting what they're. And he's vomiting after feeding. Is that after both breasts or just one breast? Is he vomiting? It seems that his stomach capacity is overfilling for some reason, and that the sphincters, top and bottom of the stomach, that's my abbreviation of it, but the sphincters are the iliosphincter and the esophageal sphincter, and they actually release the pressure. So that could be why he's vomiting. It could be something coming through your milk. It could be something totally different that needs to be investigated by a paediatric specialist. So the things that I will want to know, is he growing well? Is he feeding regularly in 24 hours, which seems to be that he is. The 1.5 hours, if that's start of feed to start of feed, that might be a little bit close, and it might be worth just extending that by 15 minutes over several days until you get them about 3.5 hours apart, something like that. That's not a set time, but it's about 7 feeds in 24 hours. Maybe that will help. I hope so. Gosh. Emily, this is from Emily Wegener. Any tips on increasing milk supply other than expressing? I lost my milk and have now got it back, but feel like my supply is not enough for my 11-week-old. Again, Emily, milk volume depends on hormone production. So stimulation of your pituitary gland is what produces the prolactin and the oxytocin that helps the milk come down through the ductal networks, contracts and helps them come down. But the prolactin is what creates the volume. There are a whole lot of things that women take, in my experience, to increase their milk volume, but it's only temporary while they're actually swallowing it, and sometimes it can be a disturbance of the baby's gut too. So smell and taste, if it's potent in smell and taste, it can be, it affects each baby differently, but that's my observation. I'm not sure how many times in 24 hours your little 11-week-old is feeding, nearly 3 months old, coming up 3 months. I'm not sure whether you're feeding both breasts per feed, with the resting and digesting in between. So I would encourage you to, you could go maybe for a period of 24, 48 hours where you just breastfeed. But if you've already been doing that, then let's try and suggest that you have 2 breasts per feed. That baby is symmetrical, is drawing the breast, not having it put in the mouth. That the baby's going to the breast very gently, drawing and symmetrical. They're very, very important in my practice. That's some of the finer points that I like to observe. And if you're expressing, I wouldn't stop abruptly. I'd ease off it gradually. So anything that we do, if we stop it abruptly, we change things too quickly. So it depends on how often you're expressing. Are you expressing both breasts? Are you doing it after each feed? Are you doing it between feeds? If you're doing it between feeds, I would actually ease off that quite quickly, because you're taking the volume for the next feed. So if you want that volume to build up. So I don't have one answer for you, I'm sorry, but I'm hoping that will give you something to think about, to see what you can do to adjust it for yourself, and maybe let me know how you go. Thank you.
This is from Diane.
Thank you. This is Diane. Diane Garcia Aquino. I hope I've said that right. So Diane says her little baby's underweight at 3 months of age. So on the graph, your baby's on a lower percentile as that. That's how my brain's interpreting what you're saying. You've been breastfeeding since birth, and you've consulted with a lactation expert, and you're in the Philippines. Your advice is that it may be because of her latch, or maybe she's lip-tied or tongue-tied. Better consult to a pediatric dentist as per her advice. Is there any other way? Can I correct it myself? Well, I have to be perfectly honest with you. I'm going to take the lip and tongue tie first. Unless there's a major problem in a family history of tongue tie of any sort, I wouldn't be doing anything till I know that my baby is symmetrical at the breast, that my baby has best possible potential using its oral cavity, drawing the nipple all the way back to the soft palatal cleft, so that the rest of the breast tissue moulds to fit your little baby's unique growing mouth inside the mouth. And it's a unique teat for every baby. Every mother and baby is different. It's very important for me not to cause babies pain, and I have seen some terrible tragedies from the trauma of tongue ties being cut. So, and a lot of my colleagues have seen the same thing. So I would encourage you to leave that alone unless you see that there is a major problem. I've had little babies who've been tongue-tied right to the tip, to the floor, tip of the tongue, to the floor of the mouth, and they have breastfed no problems at all, because they got breastfeeding right from the beginning. So their first breastfeed and the first 72 hours was absolutely crucial for that little baby to do what it needed to do to mould its mother's nipple and its mother's breast tissue to use its oral cavity. And I think for me, if I had seeing more babies like this, I would be encouraging you not to do that. I definitely wouldn't be doing here. The anatomy says that that little band is a stabilizer for the lip to the gum. It stabilizes the lip to the gum, and this one does here. There are plenty of other bands in our body. They're there for stabilizing purposes or for folding purposes. They're not there to be cut and moved. I have seen a little 17-month-old not so long ago with a huge granuloma growing up inside here because it had been cut twice. And then instead of it separating, it actually grew into a big lump inside the mouth. And that little baby was quite distressed with all of that. The other thing that is that there are some families, and there's a family history again, who have the band that comes down between here and may have a gap between the teeth. In most of those families, to my knowledge, there's not a major problem. For the ones that are, they need to see the paediatric dentists who will advise them. But there are plenty of people with a little gap in their teeth that doesn't worry them. It's a family history of it. So we don't snip them at birth, because if we snip them at birth, we don't know what the potential is for later on. The other, and it's not just snipping really, that sounds like it's not much. It's actually cutting a band that's stabilising. And the other thing is the gum grows down, and as the gum grows down, the band recedes. So the little band sits up there for the rest of our life and does the work it's supposed to do. So that would be my first encouragement to you. But if your instinct will never be wrong. So if your instinct is guiding you, you follow your instinct. And if it's saying have an opinion, go have an opinion. It doesn't mean to say you have to have it done. You can have an opinion, you can have it explained to you, and you can come away and think about it and decide what's best for you. And if it's not worrying you, then now your baby is underweight at 3 months old. I don't know what percentile the baby's on. Is the baby feeding about 7 times in 24 hours? Maybe at 3 months it might be 6, 7, it might be 8 sometimes if they're underweight. But is your baby feeding regularly with intervals of sleep in between? Is your baby maintaining its body temperature? Is its colour good? Is there any other health reason why your baby may not be gaining weight? Is your milk volume, are you satisfied with your milk volume? That's important too. Feeding from both breasts is really important to maintain milk volume because you're stimulating hormone production. Very important. If it's your first baby, if you've had any other babies and you've had small babies, there may be a family history of small babies. It may be that both parents are small. I don't know the detail. So I would take advice from your midwife or the professionals that are looking after you. If they have concerns, then maybe follow their guide and see what's happening. But I would be looking at the things that I look at would, how often is the baby feeding? How many times in 24 hours is the baby feeding? Is the baby feeding from both breasts each feed? Does the baby have time to rest and digest? Is the baby symmetrical at the breast? Is it using its oral cavity to the fullest potential as it's growing? Because it's getting bigger all the time, so it uses that breast tissue to full potential. That's what I would be encouraging you to do to correct it yourself, and I hope that helps, Diane. Okay. Couple more? Okay, wow.
Amy at the top there.
Up the top, Amy. Amy, hi. You said you haven't yet expressed milk. Your baby's 19 weeks old and has been exclusively breastfed. Well done. That's brilliant. Good on you. And you're doing very well. But you feel your supply might be declining and also want to be able to have some in case. Is there a better way to begin expressing?
And she adds a little bit in the next.
Oh, okay. Sorry, I mean, can you recommend how to begin expressing when during day, how many times? Yes, I can do that. But let me just first understand, if your baby's 20 weeks and you've got this far, do you really need to express, is the question. Are you saving it because you're going back to work, or is there a really good reason why you need to be saving your breast milk? So let's work on the assumption that you want to put some milk aside. Well, actually, you've actually said that. Breast milk volume so the baby grows and plateaus. So breast milk adapts to that. The baby will increase when it's growing and it'll plateau and things will calm down. So maybe your baby's on a plateau where it's not growing so rapidly at this point in time, but it will take off and grow again. So maybe that's why you may be feeling that your milk supply might be reduced. But the important things are, is your baby swallowing? Can you see your baby and hear your baby swallowing regularly during the feed? Is the wheeze and poo volume good? Is your baby maintaining its temperature? Is its colour good? Is the baby active? Is it communicating with you? All of those things are very important to know whether the baby's getting enough volume from you. Also, your milk volume does settle down where your breasts feel sometimes a little bit loose and you think, oh gosh, I hope I haven't lost my milk. But you actually haven't. It's just everything settles down and becomes relative. So just keep an eye on your feeds and watch carefully. When the baby's finished stimulating, does it begin swallowing? And does it do that several times on one breast and several times on the other breast as well? That will give you some, there's no count, but do you know what I mean? It's just observing that that's happening. And that will give you some information about feeling confident about your milk volume. Now, if you want to begin expressing, what that does is changes the cycle and the rhythm of your pituitary gland. So in my experience and with the women that I work with, the best way to express if you're wanting to collect your milk is to express at the end of each breastfeed, not between feeds and not in the morning and not in the evening, because you're removing milk from the breasts that the baby would normally be building up for the baby to have for the next feed. So that's what I mean. It interrupts the cycle that you've already established with your baby. So if you want to collect some, you won't get a lot of volume. You'll get some and you'll just add to it and collect it till you've got enough to store or to keep for whatever reason you want to keep it for. Very important not to, so over 72, 96 hours, you'll find that volume may increase and you might get a little bit more at the end of each feed because the baby will have reached capacity during the feed and won't want as much. But then be really careful that when you're going on this journey that you're not oversupplying too, you're not over creating an over volume where you end up with mastitis, breast engorgement and mastitis. It's a fine line. It's a really fine line if you want to do all that. But our breasts and our bodies were actually made for breastfeeding. So my encouragement is to breastfeed for as long as you really want to and continue with that. And how many times? I'd say each time you breastfeed during the day, depending on what volume you want to collect. And during the day is preferable because you don't want to interrupt your sleep at night. And also your prolactin levels are enhanced at night. So if you're breastfeeding your baby at night, it's much better to breastfeed them. I do hope that helps.
This is the last question.
Okay. This is from Melissa. Melissa Sessions. Melissa's baby is 9 weeks old. She rarely had both breasts in a feed. She rarely has both breasts in feed. You have a good supply. Could it be that my supply is too much for her to cope with? I feed a lot during the day, 3 and 4 times at night. So is it okay? Should I be making a feed shorter or one breast so as to feed both breasts in one feed? Melissa, I would say from this that you're doing very well and that maybe there's no need to change anything. If your baby's feeding frequently during the day and you're changing breasts, as long as that's working for you, that's okay. 3 and 4 times overnight, I don't know whether that's both breasts. No, it's not. She's rarely had both breasts. If you're maintaining your volume and you're happy with what you're doing, I probably wouldn't change anything. So should I be making a feed shorter on one breast so as to feed from both breasts in one feed? It's not about the feed being longer or shorter. It's about the baby reaching satisfaction. So, for example, if the baby's been having for 9 weeks 1 breast per feed, rarely feeding from both breasts, that volume, because you're using the fullest breast, will be enough to fill your baby. But what happens by the time you get to the next volume, that's really high too. And sometimes in my practice, or a lot of times in my practice, by the time you get to 3 months, your milk volume is actually reducing because you haven't been using both breasts every feed. Now, that's not everybody, but it is many people, because most of the women that come to see me have a problem. So when we analyse and we look at what the problem, how it stems and what the history is and where it comes from, then we can work back to see what may have happened and what we could change. But at the moment, it seems like you're okay. Again, it would be the same advice that you would give that I gave the other lady, that if you are one-sided feeding and the breast is very full, I would probably go to the softest breast first, rest and digest, nappy change, and then when the baby's ready, when the baby gives you the cues that it's ready to feed again, feed some off the fullest breast, the one that you would have normally started on. Next feed, depending on the situation, as your breasts start to regulate down a little bit and the volume's not so high in one breast, then you'll find the baby will start going to both breasts each feed. And then you offer both breasts every feed from then on. But it depends whether you want to do that or not. But seeing you put the question, it's not about the shortness of the feed, it's about being aware when your baby has reached both gastric volume satisfaction and emotional satisfaction. Both of those are important. They drift off and they come off themselves. Then they stretch out and rest out and digest. I'm not sure whether you've watched the video. There's a couple of videos up there that you might like to watch and see how the babies behave to pick up the cues. If you're not already aware of them, I'm pretty sure you are, but just in case. I hope this helps. Thanks, Melissa.
Do you want to do one more?
Mm-hmm. I'm told there's one more.
From Rachel. And then there's another tongue tie one underneath it if you want to go there.
So Rachel has 2 questions. Hi, Rachel. My baby's 16 weeks today. Oh, my goodness. Reached a milestone today. Time goes quick, doesn't it? I had pain at first, but it got easier and less painful around 8 weeks. However, it started hurting again lately. It's possible my baby changed her latch. Is it possible my baby has changed her latch? Can I retrain her? And 2, I also think she has an upper lip tie and is not affecting her feeding. But it's not affecting her feeding. She's getting plenty and growing. Should this be fixed? I think I answered that just before, but I'll reiterate the tie part. The tie, the little bands at the top and bottom lips, inside the lips, are structural. They're there to stabilise the lips to the gum. So they're not meant to be cut. And unless there's a major problem, if you just flip back to the other question, you'll see what I've said in more detail. Unless there's a major problem, I would be doing absolutely nothing with that. It's become a phenomenon. And I'm very concerned that so many little babies are being snipped when they shouldn't be. And I've observed 2 little babies, newborn babies, who in early weeks had their both upper lip and lower lips snipped, and both of them were fibrillating almost at the breast. They weren't able to create the seal properly. So I think I wouldn't encourage you to do that. I hope that's good advice, but I wouldn't encourage you to do that. So on question number 1, you had pain for 8 weeks. So I suppose I'd start by asking you, is your baby symmetrical at the breast? That's really important, that both cheeks are snug at the breast the same, not one slightly off or the other slightly off in the other direction, but both snug against the breast. So there's no gaps. Is the chin working deep in the breast? Are the nostrils resting on the breast? And when you look, or someone looks at the side for you, or you use a mirror, can you see that these 4 points, there's no gaps? That this is just, nostrils are just sitting on the breast. The lip sits under here and creates a space for breathing. That would be the first if you've had painful nipples. If she's had teats or dummies or nipple shields, it may mean that the function of her oral cavity, she changes from breast to that, or she changes from that to breast. She alters the function inside her mouth. So if she's using a dummy, looking at the shape of the dummy, I would be gradually encouraging off the dummy so she uses your nipple and your breast to full potential, so she develops her oral cavity in the way it should be developed, not when it's narrowed down to suck on something foreign that's tight and hard. Now, I know some people prefer to use dummies, and that's totally their choice. It's not mine, but it's a whole different oral function for tongue, for vacuum, for all the muscles. And then the baby has to work out which one. So she may be doing that. She may be using a different suck on your breast if she's using an oral apparatus of any sort. It may be that she's just slipping down during a feed and you're not aware because you know there's so many things going on in life, especially at 16 weeks. And if she is, just remember to be up close, symmetrical, and also to just look occasionally and fine tune her if you have to. The pain usually relieves or will disappear with gentle, short, like 1 centimetre fine tuning, right, left, over, under, unless there's terrible damage, and then you'll feel pain, but that pain may be relieved somewhat. And the pain generally relieves or disappears when the baby starts to swallow. It's when the compression is softer. So when the baby's swallowing, it's swallow, swallow, and the milk spraying out the end of the duct, over the back of the throat, creating the swallow, so the compression is softer. When the baby's actually drawing, the compression is quite strong to get the nipple right back to the soft palatable cleft and to mould the breast tissue into the shape of the baby's oral cavity. So I think that's about what I can offer you without having more information. And I hope it gives you enough information to think and work things out. It's just any oral apparatus will alter the function of the baby's oral cavity. Thanks, Rachel. So I'm told that we're coming to an end for today. And again, I'd like to say thank you. And if I couldn't answer all of your questions, I apologise. I'm sure they'll be there and my team will be reminding me that I need to answer them all. We'll try and answer them as a priority next time. It's very, very important for me to, again, repeat that if I don't have a history, I can't advise you in the professional way that I would if I was sitting beside you working with you. But I can give you broad information based on my experience, based on my PhD research, based on my years of gathering of knowledge from wonderful women and babies. I can do that. So a detailed history to me is really the gold star. It tells me so much about how I can work with you and your baby as individuals. So for more information, you can watch the free videos that are up on, there's YouTube and my Facebook site. And there's also the breastfeeding course which we've developed, which is, this one's for women, is it? Yes. Yeah, breastfeeding course for women. I think we've got one coming for midwives as well. Yeah, we've got one on its way for midwives. But what the aim is to get midwives and mothers thinking similarly. Now, nobody's going to be the same all the time, but similarly so that before I go and depart from Mother Earth, I can have made a difference to the number of women who are breastfeeding their babies, because in Australia at the moment, only 15% of women are fully breastfeeding their babies at 6 months of age. So we want to increase that, and I am aware that the figures are similar in other parts of the world as well. So I think one woman working with another woman, one midwife working beside another midwife, and sharing and feeling the results that I was working with women with by me just having the time to sit beside to be patient, to observe carefully, and to learn. That's the women and the babies taught me most of what I know. And then I put that into a 6-chapter thesis if you'd like to look at it. It's online. And it shows you all the pictures in that of the types of trauma that I was seeing as well. So that's something that you might like to have a look at if you've got any spare time, that is. You don't have to read the whole thing. 6 chapters is too much. But anyway, there are some very interesting photographs in that as well of the beautiful women that allowed me to photograph so I could pass this on and work with women around the world, hoping that over time, gradually over time, we can increase breastfeeding rates for the benefit of our babies and for the benefit of future generations and their health and well-being. So thank you so much. Thank you for joining me. Take care.